It's now my pleasure to introduce Dr. Murad. He is a medical graduate of the University of Damascus in Syria. He completed his internal medicine residency at Danbury Hospital in Connecticut and his cardiovascular and advanced heart failure and cardiac transplant fellowships at the University of Minnesota. In addition, he also received postgraduate training in clinical and outcomes research at Wake Forest University in North Carolina. And he joined Metro Health Medical Center in 2016 and was appointed as assistant professor of medicine at Case. He currently serves as the heart failure section head in the Division of Cardiology and the director for the Heart Failure and Pulmonary Hypertension Care Center at Metro Health as well. His academic interests include the outcomes of patients with heart failure and pulmonary hypertension and the impact of non-cardiac comorbidities on such outcomes. Thank you so much, Dr. Murad.
Good afternoon. Thank you for, first I want to thank Dr. Antonelli and Dr. Weinberger for inviting me to speak to you today. And it's my pleasure to speak to a crowd of rheumatologists about pulmonary hypertension. It's a cardiac condition, but I will show you how it overlaps with what you do. I have no disclosures for this talk, except that we will be discussing a phone app that is for the DETECT algorithm that I recommend you be using for screening for pulmonary hypertension. So why is it relevant for you to hear about pulmonary hypertension? I have three reasons. First is pulmonary hypertension associated with chronic with connective tissue disease is highly prevalent. Pulmonary arterial hypertension in general is very rare, but in the patient population with connective tissue disease, it's estimated to affect about 8 to 12% of patients with systemic sclerosis and about 1 to 3% of patients with lupus and other mixed connective tissue disease and other connective tissue diseases. Pulmonary hypertension associated with chronic with connective tissue disease has a poor prognosis, even in this era with so many newly approved pulmonary arterial hypertension medications. It accounts for a significant amount of mortality in patients with systemic sclerosis, and survival is still dismal. 3-year survival is less than 50% in systemic sclerosis and about 80% in lupus. And as I mentioned, it's the leading cause of death in patients with systemic sclerosis. And this is depicted in this slide here, which is about 20-some years old, yet it's still relevant today. And as you see here, the mode of death in systemic sclerosis in the 70s and 80s was renal crisis. Now we see that pulmonary fibrosis and pulmonary arterial hypertension is rising as the leading cause of death in systemic sclerosis. So convincing you that it's important to talk about pulmonary hypertension, the outlines of my talk today is to just give a general overview about what is pulmonary arterial hypertension, what is the pathogenesis and pathophysiology of this disease entity, how do we screen and diagnose, and what are the goals of management. So definition of pulmonary hypertension, it used to be mean pulmonary arterial pressure above 25. Just in the recent guidelines about a year ago, that number was lowered to 20 millimeter mercury in order to detect patients who we used to call them pre-pulmonary arterial hypertension. So this is the definition: 20 millimeter mercury for the resting pulmonary arterial hypertension and exercise pulmonary hypertension. How do we classify pulmonary arterial hypertension is basically the way I like to put it is that there is either increased flow in the pulmonary arterial bed, or there is a downstream obstruction, or there is decrease in the capacitance of the pulmonary vascular bed. We're going to focus on the third one, which is reflective of pulmonary vascular disease as opposed to left heart disease that leads to obstruction in the downstream. That's the most common cause of pulmonary hypertension and heart failure. But when it comes to the pulmonary vascular bed, we can have a rise in pulmonary artery pressure due to either vasoconstriction. We see that in hypoxia and lung disease. We can see that in occlusion due to thromboembolic disease. But the one of most interest is the pulmonary vascular remodeling. And that's what we're going to focus on. And that pulmonary vascular remodeling is driven by inflammation, hypertrophy, and fibrosis, and pathophysiological processes that happen in patients with connective tissue disease. Back to the classifications, the World Health Organization put this classification together about 30 years ago, and it's still valid because it reflects the pathophysiology and the mechanism and the hemodynamics. So the first group, WHO 1, pulmonary hypertension or pulmonary arterial hypertension, is the problem is in the vascular bed. In the other kind, the group 2 is the problem is in the left heart. Group 3, the problem is in the lung due to hypoxia. Group 4 is obstruction due to thromboembolic disease. And group 5 is a mixed entities of hematological disorders, sarcoidosis, and mixed etiology of all the other 4 groups. And just to kind of give you an idea of how in connective tissue disease patients, all 5 entities can coexist. We have pulmonary vascular disease. We oftentimes get left heart disease, either diastolic or systolic. We get interstitial lung disease and hypoxia, and especially in patients with lupus, we sometimes get thromboembolic disease due to hypercoagulable states. So we're going to focus on the group 1, which is the pulmonary arterial hypertension due to pulmonary vascular disease. What is the pathophysiology? I mentioned earlier that there is inflammation, there is hypertrophy, and at the end of the day, there is an imbalance between vasodilation in the pulmonary vascular bed and apoptosis and vasoconstriction and proliferation. This imbalance happens due to rise in the vasoactive proliferative mediators such as thromboxane and endothelin 1. There is decrease in the anti-proliferative mediators such as nitric oxide and prostacyclin. There is a milieu of hypoxemia and inflammation and vasoconstriction, leading to oxidative stress and ischemia in the pulmonary vascular bed, leading to intraluminal microthrombosis, hemorrhage, and fibrosis. And this is depicts what the pathophysiology. So the pulmonary vessel gets thick, some hemorrhage here, and remodeling. And remodeling turns this lumen to this one, and now you have what I call it a rubber hose turning into a lead pipe. And who pays the price is the right ventricle. So the right ventricle that used to a low pressure, now it has to deal with systemic pressure and becomes more morphologically like a left ventricle. At the cellular level, you will have these processes going on into the endothelin, the nitric oxide pathway, and then the prostacyclin. And we will see later on that those are targets to therapy, that we use them for to target therapy for pulmonary arterial hypertension. There are some added insults to the pulmonary vascular bed in the connective tissue disease patients due to inflammation. And you can see here cellular inflammation, immune complex mediated, and cytotoxic. And at the end of the day, you have pulmonary vasculitis and vascular remodeling leading to RV failure. So we did go through these in the slide. Insults, I apologized for the slides. There's some that might be duplicate. So this is the end results here, that we have this low pressure, high capacitance blood vessel turning into high pressure, low capacitance blood vessel. So what is the impact on the hemodynamics of the right ventricle? And this slide tells you why I'm here, because we need to diagnose these patients right in this time frame. So the pulmonary artery pressure is going up, and the pulmonary vascular resistance going up. Yet the right ventricle is able to adapt and maintain a good cardiac output, good flow. The right atrial pressure is down because the right ventricle is still able to manage. So there is no symptoms, no congestive symptoms, and no low perfusion symptoms. So this is the asymptomatic patients that has pulmonary hypertension. Now, once we get to the point when the right ventricle starts to fail, the perfusion drops and the congestion increases, and the patient will present with right ventricular dysfunction, fatigue, dyspnea, and edema. And when we get to a point where the right ventricle has completely given up, the pressure can falsely drops, and now we are in a situation where we're dealing with rather end-stage RV failure, and there's not much that halting the pulmonary vascular remodeling going to do at this point. So this is what happened at the RV level. It initially adapts in a way that's similar to what you would see in a patient getting pulmonary embolism, by dilating and then by changing its properties and its elastance. And now we have a right ventricle that behaves like a left ventricle, able to manage, and eventually it fails. This also depicts the different stages of the right ventricle, going from this shape to this, and then finally to end-stage heart failure. So the key is to improve outcome is to diagnose pulmonary arterial hypertension before the development of right heart failure. So how do we do that? So this is the spectrum of symptoms that you would imagine, initially asymptomatic, and then symptoms that are not very specific, and you encounter those symptoms in your patients for various non-cardiac, non-vascular reasons, dyspnea, fatigue, etc. As we go down the list, we have symptoms and signs more specific to heart failure, but the diagnosis is made late. I made the case that we should be screening for pulmonary arterial hypertension, but who to screen? The problem with every chronic or rare disease is screening everyone is not practical for many reasons. So you need to go and find those who might have a higher prevalence, higher than average prevalence, and target these people. The ones highlighted in yellow, these are the 4 groups that screening for pulmonary arterial hypertension is recommended. And the 4th one is the scleroderma because of the high incidence in these patients. Now, in patients where the incidence or the prevalence is lower, recommendation is to start screening after symptoms have evolved or at the onset of symptoms. And those are the patients with lupus, mixed connective tissue disease, dermatomyositis, and rheumatoid arthritis. What tools we have? First, we have to look for symptoms, because as you see, the symptoms can be nonspecific. Patients asymptomatic with further history, there is fatigue and sneaking in. There is some dyspnea, some exercise intolerance, and so on. So once we found the symptoms, or for scleroderma in specific, before we find the symptoms, we go in a stepwise approach as far as screening. What is recommended in your guidelines is that we start with a pulmonary function test, ECG, a laboratory test looking for congestion, and for identifying those patients who might have a higher incidence of pulmonary arterial hypertension, and then echocardiogram and right heart catheterization as the definitive diagnostic tool. One word about the anti-RNP antibodies. It turned out that this biomarker has, it indicates higher incidence, yet it's a better prognosis. So if you find this, this marker in your patient with scleroderma, definitely intensify screening for pulmonary arterial hypertension, but they know if they have it, they will fare better than others. So about 10 years ago, the DETECT algorithm was put together based on these signs or these markers of high risk, markers related to lung mechanics, some related to clinical findings, and some related to biomarkers and findings of RV involvement based on ECG. And then these will lead to echocardiogram recommendations, and then right heart cath. So how do we do that? So this is the DETECT algorithm app, and it puts this together and makes it easy to utilize this algorithm, starting with finding the biomarkers, by finding the clinical evidence, and moving on with the recommendations. So I'm going to apply this to this patient. This is a 55-year-old female, comes to established care with you. She has a history of systemic sclerosis diagnosed a few years earlier. And now the question you ask, do you need to screen her for pulmonary arterial hypertension? She's asymptomatic, she has no signs of heart failure, and on physical exam, she has no telangiectasia. The first layer of testing, obviously, as we said, ECG, which is normal in her case. PFTs showed reduced forced vital capacity, and DLCO of 80%. The NT-proBNP is 100, and the anticentromere antibodies are negative. Urate level is 20. So you plug this into the DETECT algorithm, and the score you come up with is showing that she does not need further screening at this point. So echo is not recommended. So this same patient comes to you 2 years later, and now you repeat the pulmonary function test, and now there is a decline in the diffusion capacity, and basically her vital capacity has remained the same. There is a rise in the NT-proBNP, indicating that she starts to have more pressure overload on the right ventricle, and no change in the other parameters. Using the algorithm again, and now you see that her score has gone up above 300, and now echo is recommended. So the echo gets done, and now we see the two markers on the echocardiogram that we look for is the tricuspid valve velocity, as well as the right atrial size. So the right atrial size 16, the tricuspid velocity is 2.6, and if we plug those into the DETECT algorithm, you come with, right heart cath is not recommended at this point. So the echo is reassuring that we have not developed pulmonary arterial hypertension yet. That patient is not out of the woods. You keep an eye on him. A year later, an echocardiogram is repeated, and now the right atrial size has gone up to 20, and the velocity, which reflects or estimates the pulmonary arterial systolic pressure, is 2.9. If you plug those back into the DETECT algorithm, it says that right heart cath is recommended. So right heart cath is done, and this is same patient. Now we have a mean PA pressure of 28 with wedge pressure of 8, reflects that this is a pre-capillary vascular disease. So this is a patient with early stage pulmonary arterial hypertension caught early on before the right ventricle has shown any signs of dysfunction or failure. So this is where we like to meet those patients. So this patient gets complete their workup, and the workup that is required for every patient is first to rule out other pathologies or other processes that can lead to pulmonary hypertension that can overlap. Interstitial lung disease with high-resolution CT, ventilation perfusion scan to evaluate for chronic thromboembolic disease, rule out liver disease, and rule out other entities such as HIV and hematological disorders. In certain situations, we do also rule out structural heart problems such as chronic right-to-left shunt, and genetic studies to rule out the BMPR1, which is the cause of the hereditary pulmonary arterial hypertension. So this patient, we established the diagnosis. After we established the diagnosis, we established the functional capacity, and we do that in two ways. The 6-minute walk test is a gold standard, but sometimes we do also the cardiopulmonary exercise testing to evaluate for and other etiologies of fatigue, et cetera, that non-cardiopulmonary. This patient fared well, by the way, and she is class 1 symptoms, doing great on dual therapy for pulmonary hypertension. So what are the goals of management? Once we screen patients, we need to talk about what's the management goals here. So risk assessment, the newer guidelines, both the American and the European guidelines, focus most on stratifying patients into a risk category. And then once the risk assessment is established, we talk about treatment strategies, timing of starting the therapy, selection of treatment, assessing response to treatment, identifying the subgroup that may benefit from immunosuppressive therapy like lupus and mixed connective tissue disease patients, managing comorbidities, considering anticoagulation, which becoming less and less favored in most of these patients, and managing the RV failure when it occurs early on, and considering advanced therapy, including possible lung transplant. This is the algorithm for assessing risk, putting the patient in a risk category. So low risk are patients who have no evidence of RV failure. They're doing fairly well with functional capacity, 6-minute walk test. They're doing more than 440 meters, and they have no specific structural abnormalities indicating RV failure. Intermediate group are patients who started to have symptoms and start having limitation to their functional capacity with evidence of congestion. And finally, the high-risk group is the patients who have developed RV failure. And we tailor therapy based on where the risk group of the patient. So it's hard to believe that only 40 years ago, there was no treatment for this fatal disease. And now, as you see, a newer therapy is being added every year. In the mid-90s, we had the prostacyclin analogs, which is still the main treatment, especially for high-risk patients. And then in the early 2000s, we had the endothelin receptor antagonists and the PDE5 inhibitors later on. And then most recently, a month ago, a new group of drugs is approved, the first one in that group in the activin binders, the sotatercept, which was approved just in April. Where those medications work, as I said earlier, they work on one of these three pathways, on the endothelin pathways, that's the endothelin receptor antagonist. On the nitric oxide pathway, whether the PDE5 inhibitors or the soluble guanylate cyclase stimulators, and finally on the prostacyclin analog pathway, whether the prostacyclin analogs or the IP receptor agonist, selexipag. The newer drug that I talked about, sotatercept, has a unique mechanism that's not related to the others, which is it's a novel fusion protein. It binds to the activin growth factors and lead to or recreate the balance between anti-proliferative and pro-proliferative pathways. And it's approved as an add-on therapy. So let's apply it to a patient of mine. Unlike the first patient who I met very early on in the game and was able to get her stabilized for now going on 4 or 5 years. This lady, she presented in 2017 with scleroderma, had interstitial lung disease and GI involvement, and 3 years prior to her arrival, she was diagnosed with PAH and started on monotherapy with endothelin receptor antagonist. This is her initial evaluation. She is already functional class 3 symptoms, elevated BNP, right atrial size is 25, and she's very limited in her functional capacity, doing only 200 meters in 6 minutes. And the question is, do I need to escalate therapy? If you plug her into the risk assessment here, she falls in the intermediate risk, which calls for dual therapy and possibly escalating based on response. So if she was already on the endothelin receptor antagonist, we elected to add an agent into the nitric oxide pathway, and we went with the riociguat, which is the soluble guanylene cyclase stimulator. She did well on this dual therapy. For 12 months later, she's down to functional class 2 with normal volume status and minimal requirement of diuretics. Her echocardiogram showed improvement in her right ventricular function and her PA pressure. And her 6-minute walk, she went up from 200 to 360 meters. And that is significant for these patients who are very limited in what they can do. 5 years, she did well for 5 years. 5 years later, she presented after she recovered from a COVID, and she's now functional class 3 to 4 symptoms, and with rising diuretic need and high BNP. Echo showed the RV started to dilate and is failing because systolic PA pressure went up. We admitted her to the hospital and they repeat her right heart catheterization, and now she has low cardiac output and high PVR. So what's the next step? Now she is in a high-risk group, and we decided to add the third agent. So as you see here, it's a stepwise approach. Those patients need very close monitoring and an escalation of therapy as it goes. So we added the prostacyclin analog initially with infused treprostinil, but she was overwhelmed with the infusion, and we switched her to, at that time, was newly approved oral treprostinil Orenitram. So that was added at that time, and she did well for 2 more years with reduction in the beta natriuretic peptide, improvement on the echo, until recently, just a few months ago, she presented with worsening dyspnea and worsening RV failure. 6-minute walk, unfortunately, she couldn't finish 160 meters, and she's on a rising need for oxygen. So the question, what should we do at this point? This is the point where the problem no longer is the pulmonary arterial hypertension, and rather it's the RV, end-stage RV failure. So she was offered admission in the hospital to transition her to the infusion treprostinil, which she had refused in the past, or adding the sotatercept, which just got approved, or consider palliative therapy. Unfortunately, because of her age, she is not a candidate for a lung transplant, and because of her high oxygen requirement, she would do poorly with the palliative right to left shunt or atrial septostomy, which sometimes we do to relieve the right ventricle. So in conclusion, Pulmonary arterial hypertension is common among patients with connective tissue disease. Pulmonary arterial hypertension, CTD, has worse prognosis than other forms of pulmonary arterial hypertension. Screening and early detection are essential to improve outcome of PAH-CTD, and close monitoring and tailored therapy must be delivered in a PAH expert center. Thank you very much, and I'll take any questions once we're done.